Good afternoon. My name is Brian Schumark. I'm the CEO for Prairie Mountain Health. I'd like to really thank everyone for coming out and showing the interest this evening. We are very excited about this project, and I know you will be as well. So the project was announced back in 2021, and there's been a lot of work done since then, but Neepawa will definitely be seeing a newer, bigger increase in size for acute care beds, expanded emergency department, enhanced space for a number of other programs. So today we're going to have two main speakers. We're going to have Debbie Poole, who's our regional lead of clinical planning for Prairie Mountain Health. So Debbie, she'll be speaking first. We'll then actually have someone from the architectural group, LM Architectural. We'll have Matthew Bowering to really explain a little bit about the detail of the facility. But before I turn it over to Debbie, I just want to say that we want to thank everybody who's participated, especially the staff, the physicians, who have really provided a great amount of insight into what this facility needs to provide and how it needs to work in terms of offering services to the communities and neighboring communities. And I just want to say too that we want to thank all the partners, including the Neepawa community, other municipal leaders, the health auxiliary, anybody that we've worked with and will be working with, thank you, because it does take all of us to accomplish such a large task. So thank you very much. Debbie, I'll turn it over to you.
Thank you very much, Brian, and welcome. And it's an honor and a privilege to be here today to talk about the Neepawa Hospital. So what I'd like to do before I turn it over to Matt is just to give you a very high level of how we got to where we are today. And so, go to the next slide. Thank you. So there's phases that you go through before you get to the actual putting the pilings in the ground and everything that's related to the capital. It's building the plan and how do you get there. So the very first thing that we did starting back in the summer of 2021 is we worked on what is called the functional program. What the functional program does is it looks at currently the services that are provided in the Neepawa Health Centre, looks at the community members that access the care in the surrounding areas and what they're coming to that health facility for. But it also looks at the community at large. So it looks at the health status of the community, it looks at the growth of the community. So as you're planning going forward, you're planning for the health services that are currently happening, but the health services that are required in the future. Once we had the functional program developed, then that goes into what we call schematic design. And what you're seeing on the back posters there is really the schematic design. And what we're talking about there is where programs should be based in terms of adjacencies. So critical things in terms of it's important to have certain programs close together. So I'll give you an example like in an emergency department. So in the functional program, it very much showed us that there was more need for more emergency room treatment spaces. So currently, I believe there's 2 or 3, sometimes you extend that out a little bit more, but you do need a little bit more space based on the volume that you're seeing, but then also on the future growth. So in the diagram you see in the back, that's gone to actually 14 rooms. So to plan for future growth, and in addition to if anybody needs to stay overnight and needs to have really close observation, that can be managed in the emergency department. So just to give you a sense of how we look at planning, looking at the current needs and looking at future needs. After we get that block design done, so again, I'll just go back to the emergency department. Some people may wonder in the functional program and in the schematic design, why did you decide that the emergency department is where it is? So it's on the first floor, but it's critical, it's important to be close to diagnostic services. So things like x-ray, ultrasound. So strategically, that's where it's based on the plan, and it's on the first floor because the general public coming in, obviously, you need to have access to the first floor. So once we get the schematic design done, then we get into what is called detailed design, and that's where we are right now. We're getting close. We're about 6 months out to finish detailed design. In the detailed design, what we're talking about is each of those rooms in those areas and what do they need to have within that room. So in an emergency department, in an area where you're coming in for acute care, what do you need to have in that room? And so that's where we're at right now, is just finishing off the detailed design. There's some things that we've done to absolutely bring frontline staff, physicians in to talk about the design of the room, and we've developed 10 mock rooms. So as Matt goes through the presentation, you will see some of those mock rooms. They're actually at Breaker 16. Some of you may know that there's a warehouse in Breaker 16 and that space has been rented. And we've actually built the rooms to scale. So when staff walk in, they get to see how big the room is going to be. They're going to get to see what's in the room. Some of the features that you'll see and that we'll Matt talk about is every room is a single room on the inpatient side. Every room has its own bathroom, its own shower. So staff then get an opportunity to go into that room and now think about how am I going to work in that room. And that helps us determine equipment. It helps us to determine how our workflows are going to go. I will say that we had that open for 3 days. We had over 40 staff and physicians come. We had some retirees also come, but we had staff repeatedly coming back to those rooms to give us some feedback. So in the mock rooms, there's stickies. Everybody had an opportunity to place their feedback, what they thought we should place. And we've gone back and we'll redesign some of that based on the feedback and do some changes, and we'll still have people come back through the next 2 months to go back through those mock rooms. I just want to say that we're very thankful. The staff and the physicians have been phenomenal in participating in all the meetings. They've been virtual meetings, and they've been absolutely phenomenal coming at the mock rooms and providing us feedback. They email us with some more suggestions in terms of things that come to mind as they're working. I've gotten faxes, and so I just want to say that it's just been absolutely phenomenal with the staff input and the physicians, so thank you very much. Now I just want to, in terms of engagement, so we have definitely reached out to other partners in terms of some suggestions in terms of what should be in the new hospital. So there's been things like surveys, so engagement October surveys, and there's also been many focus groups. I'm sure you're all worried about how are we going to staff this building, and we're worried about that too. So we've been working feverishly on a human resource plan in terms of how we're going to be able to staff. We have developed and worked with the town of Neepawa, the Neepawa Settlement Services and the Economic Development Officer, the Assiniboine Community College and Advanced Education, which is the government of Manitoba, on a proposal to deliver an LPN program in Neepawa. So it's gone to the very last stages of approval, and we're just waiting to hear if we'll get approval to actually run a program. The hope is that in September that we'll be able to start taking some applications. So we're waiting feverishly to hear whether our approval has been accepted. Our next steps, so we've got lots of work to do. We're certainly not done by any stretch of the imagination. We're going to continue to work with the mock room reviews with the physicians and staff. So we'll be continually doing that for the next few months, having staff come back through, provide us some more feedback. We'll be engaging with the Health Auxiliary and the Foundation, so some of you are here tonight, so thank you very much for coming. The Healing Garden, I know is a cherished garden within the current Neepawa Health Centre. So we'll be talking about how to move that into the new. You'll see in the plans, again, and I have to stress what you're seeing right now in those billboards in the back is draft. It will change, but there is a placeholder for the Healing Garden. So we need to talk about the perennials that are there and annuals and who manages all of that and how we're going to incorporate that into the new design. We're going to continue to work on the human resource strategy for staffing and how we're going to staff that new hospital. So it's just not nursing staff, it's everybody from dietary, to maintenance, to housekeeping, to clerical staff, to volunteers, physicians. So lots of work to continue on the human resource strategy. Planning for equipment, I'm sure you can imagine going to the hospital that is envisioned in the back there and all the equipment needs. So we're planning on what are all those equipment needs, and then how do we buy all of that? How do we get it in place? How do we check it for operations ready, that it's ready to go? Planning for operational readiness, this is a massive, massive component of it. So again, transitioning from the current hospital into the new, what does that look like? There will be a phenomenal amount of staff and physician education that will need to occur. The building is to be fully digital, so meaning that there'll be an electronic patient record. So we'll be moving away from using a lot of paper into an electronic format. So with that, there needs to be a lot of education. So we need to do lots of preparation to get staff orientated and used to all of those systems. And then again, before we actually move in, there will be a public open house. So meaning that before we take occupancy, meaning that we have patients in the facility, we will open it up for general tours for yourself to come in and have a peek. So with that, I'd like to turn it over to Matt to actually show you some of the components of the new facility. Thank you.
All right, super excited about this turnout. We've been working on this project for probably about 1.5 years now, really 1 year into active design. And so we're really excited to be able to share some of what we've been working on and a lot of the work that's been done and input from the facility and the region and all those involved. As noted, so we're about 2/3 of the way through the design process. And so we've got lots of what's been produced now, but it is still in progress, so some of this will be changing. Some of this, they'll say, well, why does that drawing look all gray? It's because we haven't got around to putting all the finishes and touches on it, so some of the stuff is preliminary and will continue to evolve throughout the process. So we'll start, give you a bit of the overview of where the design is at this point. We'll start with the site and some of the development of that, and then go through the outside of the building, and then we'll go through each of the floors. There's main floor, second floor, and third floor, and touch on some of the key spaces that are in there. So as we look at this first slide here, the first thing I'll draw your attention to, which is very small in this slide here, but just the general location of it. So we are just north of Highway 16, between the river and High Life, in the field there. And the parcel of land we're on is about 39 acres, so it's a smaller portion of that larger area that's being developed. Within that here, I'll give a quick walkthrough of how the site is developed within the parcel that we have. As we come in, there's the main connection, which will be across from where the Manitoba Hydro building is. And in coming in, the building's obviously here in the center as the white portion, and we have most of the public access and parking areas are on the one side of the building, and then the staff and service areas are on the other side. Our main front entrance comes in just from the south side here, and you'll be able to see a little better in the next image, but we're not going there just yet, that all the parking, specifically from the public side, is quite close to the entry points. And there's a good drop off, it's accessible, so we'll have all concrete sidewalks in that to avoid tripping hazards, so it's really designed to accommodate everybody and all accessibility levels, and to really minimize a lot of that walking distance that you would have. So the key entry spot for most public outpatient visits is coming into that front entry. We also, on the north side here, have the emergency department. So it has a separate entry so that as people are coming in through signage and visibility seeing large emergency sign, it keeps those paths separate and also has the ambulance garage on there. So we'll look at that a little bit more as we go into the building. The other key item to note on here, we have this circle just off the edge of the ambulance garage. That's for a heliport. So we're working to have a properly certified heliport so it can be landed in all weather and is properly registered with all the flight services and that. So that'll be just an appropriate distance away from the building and able to accommodate that type of access for the area. The last spot on the site plan, which is probably one of the more important ones, just adjacent to here, which is outside of where the cafe space is, on the inside of the building, we have that healing garden space that'll be developed and worked through with both some of the existing input and to develop amenity space for family and staff in that area. And then the one last item, off of the staff parking lots here, we have a separate staff entry, so we'll see that as we go through the plan as well. So, as you see in this image here, this is looking at the front entry, so from the south side. The entry is just here underneath this canopy area. You'll see it's a 3-story building. So on the left side here, you're just seeing one end of the inpatient wing. There's 2 stories of inpatient rooms. On the right side here is where the outpatient programs are. So we'll see that as we go through the main floor, and that's just a single level area of the building. In the center of the building, you'll see on each of the floor plans, there's a central atrium that you come into right at the entry, and it creates a large, sort of public space that's light-filled. And as you're moving around the building, it helps orient you because you always come back and see, hey, there's the atrium. I can see where I came in from the entry and that. So as you're getting off the elevator, it really creates a central point that's easy to navigate through the building. And really, no space is too far off that central atrium as you're moving through the space. And you can see from the parking lot, really we're at about the farthest edge of the parking lot on this front side of the building, and you're never really more than about 10, 15 parking stalls away from an entry point for it. So really trying to keep that by having those different entries and having those places separated helps work with the walkable access to the building. All right, so we'll touch on a couple of the program highlights. Debbie's already touched on a few of these things. The first one here is that we have 60 private bedrooms. So where most of us are used to being in multi-patient rooms, everyone has a private bedroom. And in the washrooms, we do have a shower associated with those, really to support that patient experience. As we go through the inpatient floor plan, we'll touch on, we have medical beds, surgical beds, bariatric care, airborne isolation, and palliative care beds within those, so we'll touch on those. In related to obstetrics, we have 2 standard LVRP rooms, and we also have one that's specialized to have water birthing capability within it as well. So I'll show you a bit of those on the plans. In the emergency department, there are the 14 treatment bays, and those are segregated to different acuity levels and functions within that, so we'll look at some of those. In the outpatient treatment area, this is a clinic function, but it's not like a family clinic, it's more acute care. A lot of things will be currently happening in emergency department, but are not emergency related. So we'll touch on how those work. And then the other outpatient programs are cancer care, where we have 6 treatment stations, and renal dialysis, where we have 9 treatment stations. And then up on the second floor, we have surgery, which has 2 operating rooms, and then 2 procedure rooms, and one of those procedure rooms is specific for endoscopy. So let's take a look at the main floor. So in the building, just to orient from that last image we were looking at, it would have been looking towards this main entry here. And so our inpatient wings, which are on the upper floors, create sort of an L shape with that atrium space in the center. There's also some future expansion opportunities on this, knowing that over the lifespan of the building, as communities grow and as needs change, there could be additional opportunities. So for example, adjacent to the emergency department, there's some area that we've kept clear from equipment and other planning things so that if the emergency department does need to grow, there's opportunity for that to be additional things, additional space, as well as some other areas around the building where there's some intended growth potential. So as we go through the plan, the next 3 areas we're going to look at. First, we're going to start with this southeast corner. Then we'll look at the emergency department and diagnostics, and then we'll look at the outpatient area. Just as a general overall wayfinding, you come in through the main entry down here into this green area, which is the atrium. From there, a majority of patients that are coming for visits will either be going into the outpatient programs, to diagnostic imaging and the lab, or up these elevators to the inpatient and surgical programs. So really trying to keep that to easy wayfinding and opportunities. And then that other access point is into the emergency that we'll look at in a little bit more detail. Yeah. So on this one of the things you can see just off of the atrium, we have the elevator core. And so we'll have 4 elevators in there, and 2 of them will be facing the atrium, which provides public access up to the upper floors, and then the other 2 are facing onto a staff-only corridor, so that you have separation of your carts, your solid waste, and all these other items, and then even patient transfers that will be separated from each other. And then throughout the rest of that main floor, it really keeps that separate all the way over to the emergency department from the public access, so that it works best that way. As we come across to this wing here, in the green, we have occupational therapy and physical therapy. So it's one of the outpatient programs, and it has the access for that. And within there's activities of daily living. So there's a residential kitchen, a residential washroom, so as people are rehabilitating, they have opportunities to learn those skills and some of the things they'll encounter as they get back to their house. The rest of this wing is some administrative offices and some meeting rooms, as well as on-call rooms, and some of the other functions would be related to that. As we're in the public zone here, we have opportunity for a gift shop that would be coordinated with Foundation Auxiliary, as well as the cafeteria. So it's banked onto the main kitchen and has opportunity for servery, as well as a public dining space within that. As we continue to move down this wing, directly adjacent to the main dining space, we have the main staff lounge, so that as you're on breaks in that, you can come out to get food, you can come back. This whole area is meant to be very nice. We're having a double-sided fireplace so that can really have a nice feel and relaxing and rejuvenating space. We have our main staff entry just at this large arrow here that comes in. There's some change rooms and other staff spaces associated with that. And then the pharmacies at the end of this wing here, so that it's off that staff corridor from a security and safety standpoint, and good access up to the upper floors. So this is an example of an image of what the cafeteria might look like. And so to the left are the windows that look out towards the healing garden space. And then just behind us to the right would be where the servery is, where you pick up food and come through. And then just on the other side of that fireplace wall is where a similarly sized room would be for the staff amenity space. So as we come over to the north side of the room, and just for orientation, just off the south side of this picture is where that atrium space is. So from a public standpoint, you'd be coming in, and just at the entry point here, we have the waiting room that serves both the lab and the diagnostic imaging area. So from a lab standpoint, we have the phlebotomy, where samples and specimen are taken, and then that flows back into the rest of the active part of the lab. And then in this blue area is the diagnostic imaging. So within here, we have 2 X-ray, we have 2 ultrasound rooms, and we have 2 ECG Holter rooms that also can accommodate stress testing as well. So that forms the main area within the diagnostic imaging. Off to the left here, we have all the back of house spaces. We have laundry, we have housekeeping, there's the loading dock and supplies and materials management. And then that purple area is some of the mechanical electrical spaces on this floor. Up in the orange area here is our emergency department. And so we'll look at that in a little bit more detail in the next slide, but some of the key factors within here is that we have close access and adjacency between the emergency department and X-ray. And then also from the ambulance garage, about half of the visits to the hospital are non-emergency stretcher service type visits. And so they can skirt along the side of the emergency department, either come to diagnostic testing or head up to inpatient, or different actives that would come through from the ambulance bay. So that was a conscious part of how the ambulance bay is attached onto the emergency department. So if we go to the next slide, we have a 3D view of the emergency department, and I'm sorry it is upside down from the last slide we were looking at, but if you look at it, so we have the ambulance garage here that has the access through on the road, and then the main public access comes in on the left side here. So there's a couple key zones to how this area is laid out. At the front we have the public waiting room for the emergency department. And within that, we have enclosed rooms that we'll see in another image here that shows the triage and registration rooms. And so they're a closed room, so you come in and have a private discussion with the nurse and registration to share your information. And then from there, we flow into the active part of the emergency department. So within here, you can see this core area with all the desks. It's really quite an open space, so it doesn't have walls that go up to the ceiling. And then surrounding that are all the key treatment rooms. So these two large ones at the front are the trauma rooms that are of the highest acuity, almost to a operating room standard. Then around this side here, we have the standard treatment rooms. And then on this side, we have a rapid assessment zone for less acute cases that are more tailored to that quicker throughput and able to handle the different acuity levels. We also have a couple specific mental health rooms that can handle mental health assessments, so that they're not just in a standard treatment room, but able to have a specialty or laid out in a way that's appropriate for that type of consultation engagement. And then down the back half are a number of the support spaces, some office and meeting space, and soil and clean utility spaces that help support what goes on in the rest of the emergency department. So the core of it is really this open, active zone that staff can have good communication with each other and be able to see all of the spaces that surround off of that. Okay, so if we go to next slide. So this is a view of the waiting room. And so the entry comes just down at the back side of here, and have a pleasant open waiting space, as well as you can see some of these glass doors that head into the registration triage spaces where the information is taken. So that's sort of the key entry space as we're coming into the emergency department. So on our next slide here, we have some of the pictures of the mock-up spaces that have been done over at Prairie 16. And so some of the last images in that, other than the people that we put in to make it look more interesting for you guys, as we've been working with staff in our user group meetings and that, we're working both on plans. We have some of the 3D images to help understand how the spaces are being used and worked. But another key part of it is, some people work well and understand technical drawings. Other people really don't. So there's nothing that really beats actually seeing it full size in person. And so we did, I think it's about 9 or 10 key rooms around the space. So we'll show you some of those images as we go through. And so we have them mocked up. And so they put wood studs in, put some poly over them, and then you'll see pieces of paper and Post-it notes and some old hospital equipment that Debbie and the group were able to find, so that you really have an experience of, if I'm standing at the patient bed, what am I reaching to? What spaces do I need? Where's the handrail, or the hand wash sink? What kind of spaces do I need to be able to move around the bed and that? So these are really invaluable and a fairly important factor that really gets a lot more information and input from staff. So on the next picture here, we have, this is one of the treatment spaces in the emergency department. And so as you can see here, we have the light, procedure light on the ceiling. We have what we call the head wall, which has the medical gases, power, and data, and all these items that are right at the head of the bed for the different equipment that needs to be there. We do have windows in the emergency department, and they're located up high so that there's privacy, but still able to have that connection nature, some natural light that helps increase the experience of the space. And so staff are able to provide a lot of input in how some of these areas are laid out and spaces that or the items that we have in there and how they can use them. So the next area we move over to is the outpatient programs, and so the atrium space is just off to the left of this area. The key spaces that we have in here are the outpatient treatment is in the orange here, and so this is where we have items like IV treatment, if you needed antibiotics through an IV. We have wound dressing changes. some lumps and bumps. We have space for visiting specialists that are coming in. So really general purpose clinical treatment space, but is not like a family doctor type of clinic space. The other two programs that we have in here, in the red color, we have the cancer care. And so within that, we have the 6 treatment stations. So those are all located on the outside wall in bays. We have some nice images of that that'll come up on the next slide or two. And then we have the support spaces and some exam areas that go along with that. And then we have down on the south side here, the renal dialysis. And so within that, we have our 9 treatment bays. One of them is enclosed for airborne isolation, if that's required for a specific patient. And then we have an exam space that supports that, and then all the technical support areas that are required to support this program. And one of the key things, I always say that of the patients that will spend the most time in a hospital is typically dialysis, because a lot of other people are there maybe intensively for a month or so or a day or two. Renal dialysis are really coming on a regular basis, and often require mobility aids, so having them right close to the front entrance is a key factor to how that was laid out and the proximity of that. So as we hop to the next slide, we have an image of some of those bays in the renal dialysis. And so they're meant to be open, yet private. We do have a large window at each of those bays. However, from a nursing care standpoint, it is behind the patient because you always have to have that view and access to the patient for renal care. And really trying to have nice finishes in a light-filled environment for it. And then this is over into cancer care, where we have, it's a similar layout, some different equipment, different space, but be able to provide a similar level of care over in the cancer care. So our next area we'll look at is the second floor, and we'll zoom in on a couple of these spaces as well. So a key factor here, we have the atrium is this large rectangle here, and so as you come off the public elevators, you're looking out towards, there's a bit of seating area, and you can look down, and helps with the orientation in navigation through the facility. The two key spaces that we have in here are, in the orange is the inpatient, which we'll look at on the next slide. On the green area here in the blue is our surgical program. And then in this pink color here is the labor and delivery area. So we'll take a look through each of those spaces in the next slide or two. So for inpatient, as you're noting, we have 60 inpatient beds. It's 30 on each floor, and those are divided into 18 on this side as a pod, and then 12 on this side here. And in, I'll say, the very long-term planning for the hospital, the reason one of them is longer, part of it's just staffing ratios. It works out well to be in pairs of 6. But also, if there ever was a need for a major expansion to the hospital, being able to expand out the 12 wing with the number of additional beds would be a way that you could increase inpatient, because it's really hard to either build on top of something or try to attach up to the middle of, or through a long tunnel or something to an additional space. So some of those capacities are planned in here, even though that could be a very long ways down the road. So coming off the elevators, we have a core that is shared between all of the inpatient rooms. Within that, and just recall this is the same on both floors. So on this floor, just off of the elevator, we have a spiritual room that's allocated for First Nations Indigenous ceremonies and practices. And then on the floor above this, we'll see they have a spiritual room that's a multi-faith space that can be used for a number of different functions and uses. As we come into the inpatient wings, you'll see that along the exterior, with windows to each of the inpatient rooms, we have our individual rooms, and then down the core we have our service spaces that support those, and then at 2 spaces down this wing and 3 spaces down the other, we have our care stations so that the nursing is distributed and always close to the rooms that they're supporting. For our specialty rooms that we have within here, We have a palliative care room here, which is laid out very similar to the rest of the individual rooms. However, it's a bit larger, so it has a bit more family space. It has some counter area if you were bringing in some food, or just having a bit more area for family to congregate with family member. And so we have 2 of those because there's one on each of the floors. And with the private rooms, really there is the capability to offer palliative care in any of the rooms throughout the facility if there was more need for that. Adjacent to the palliative care room, we have the patient and family lounge, which is available to all people. However, if there was a large family, it's adjacent to the palliative care room, so it has the opportunity to be used for that. And then we also have a palliative care consultation room that's adjacent to that provides a bit more privacy and opportunity to talk with a physician. The other specialty spaces we have an airborne isolation room that has specific anteroom and for protective equipment, as well as negative air pressure to accommodate that through the mechanical systems. We also have a bariatric care room, which is for higher BMI patients that require additional space and higher lifting power and more mobility area in the washroom and that, so that's another specialty room. I think I have all of our key spaces in here. Yes. And so just off of that core, here. So this is an inpatient room. You'll see within here we have, we're near the door here, and so that's the caregiver side of the room. And then over towards the window, we have the family side of the room, so some chairs there and pulled-out lounger and some of those items. In every room, we're looking to have a lift so that we're supporting the staff through transfers from wheelchairs or potentially with the fall. And then just off to the right, we have the door to the washroom and the space for that. The window in this room doesn't look that large. However, for anybody who's been to the mock-ups, they are massive windows that look out over the landscape and that. So it's going to be exciting to see how those are and the views over the town and that. So the next image here we have is of the inpatient room from the mock-ups. And you can see in here, in all these different spaces, we have post-it notes that are placed on a number of the different items, and it just the comments that we've received, make the shelf a little bit higher, we need to be able to reach this, we need another switch at this point, a number of these different items. My favorite one was, we have the 2 shelves here, and then it was meant to be closed in up at the top. And it was actually on the labor and delivery side. The comment was, only 1 shelf, and keep it open on the top because we need to be able to fit balloons and flowers there. So we now have 2 shelves, and they're open large enough for balloons and flowers. So it's through doing these things that you wouldn't necessarily pick up that when you're just looking at a black and white drawing in a meeting. So these are really invaluable in how some of the decision making occurs. All right, so as we move to the north side of the building, still connected in part of inpatient is the pink area here, and so this is the labor and delivery area, and has that access from the public elevators, and also if someone was coming in through the emergency, say overnight, there's access from the service side to be brought in as a transfer. Within this area, we have our 3 key birthing rooms. 2 of them are standard LDRPs, which is for labor, delivery, recovery, and postpartum. So you stay in that room, you don't get transferred out to another inpatient room as you would have in past times. And then this last one here is a larger room that is still set up roughly the same. However, it has a larger area at the foot of the bed, and there's a large birthing tub that's in there. And so that provides opportunity for water birthing as part of the labor and delivery. A key part of this also is that as the back entry from the labor and delivery lines up directly with the operating rooms if there was emergency C-section that was required, provides that close adjacency. So Ulr's going to go through surgical. Well, actually, might as well go to that slide because it's for the elevation. So this is the mock-up within that space, and everybody who walks in this room says, oh, this room's really big. And part of it is that we have room for the mom's bed, as well as the square here is not very exciting, but it shows the panda, the baby's care station as well, which has its own separate head wall with medical gases and access to items. So it's laid out with a decent amount of space for all of that and to accommodate what's needed. So as we come off the elevators, if you're coming to a surgical appointment, just off the atrium on the main floor is registration. So you'd come in, check in there, and then come up the elevators and come into reception and waiting here. In this green area here, on the south side, we have the pre-op area where the beds are, where you get prepped before coming into surgery. And then on the north side of the green area, we have the post-op recovery beds, so the PACU beds. And then in the center is some of the staff and support areas, that the core that supports that. From there, as we come through, on the left side here, or the right side, sorry, we have some of the staff change rooms and prep areas. And then as we come into the main part of the surgical program, we have those 2 operating rooms, as well as the 2 procedure rooms, and one of them being dedicated for endoscope procedures. And then on the north side of this bank, attached to the back of it, is the sterilization, so the medical device reprocessing that'll be processing largely for the surgical program, but also for inpatient clinical uses, and the emergency department will also have devices that are coming up here for reprocessing. So here we have a couple images of the pre and post area. And these ones aren't quite as inspiring. These are as we're working through the staffing and talking about spaces, so they're not developed quite to a presentation level. However, they are some of the ones that we had available from our discussions with staff and how the spaces will be used and set up. And so this is looking down the corridor towards the PACU side of it and some of the visibility and sight lines in that. So this one's an image of the operating room and how it's set up. And so through discussions with staff, working through how the equipment from the ceiling that's laid out, what's required in there. Working with staff, they did want some built-in storage and equipment, and so those things are all discussions we're having and working out to accommodate the requirements that are needed for these areas. And this one is very fun. For the mock-ups, we did get them to mock up actual size and some of the positioning of the booms and lights that are hanging there, so they have an understanding of how that's going to fill the space. Otherwise, it just looks like a big open room. You'll notice on here lots of post-it notes as we're receiving comments from staff in how they want to use space, and some of that equipment from the older equipment that we were able to steal for a couple months to help fill the space and have people have a good understanding of how it would be laid out and used. So we're almost done our tour. As we move up to the 3rd floor, inpatient is laid out very similar to the 2nd floor. And really, about the only difference is that the spiritual room on this floor is intended to be a multi-faith spirituals room that's accessible both to the public, or if there was a baby shower or a memorial or something, it's available for some programmed use as well. The other item on this floor, this large purple area, is a lot of the mechanical space and the air handling and that services the building and brings that all down to the lower floors. Oh, well, here's the zoomed in view of the inpatient, which is, yes, laid out very similar to the other floor. So that takes us through the building. And we have some opportunity for questions from the design lady to talk to me, or Brian and Debbie can also provide some comments.
Maybe we'll start with asking Matthew any design questions related to his presentation. So please go ahead and ask any questions you may have.
From the Brandon Sun, I noticed it's very modern looking with a big emphasis on, big windows, lots of natural light coming through, not just in the atrium, but those patient rooms and everything like that. And I guess, did you consult with a lot of people to try to find out, obviously this has a benefit on patients, are you hearing that echoed back to you through your consultations that that is incredibly important?
Yes, yeah, and within literature and healthcare research and that, there's a lot of strong evidence towards having natural distractions and natural light and views out to the world, and that are a key factor to recovery times and to supporting patient experience.
Definitely. I think that's like very much reflected. So I have a feeling, I thought maybe that's what you heard in consultation quite a bit. It looks really nice.
Is there an actual landscaping plan for the area around there, given the amount of windows and the fact that there is a certain industrial park area next to it?
So the landscape is still in development, but the initial plan is there. So there'll be, near the building, there'll be trees and planted up areas. As you move further out, there'll still be some field and farmers area around it. So it will extend a certain distance. We will be planting up the whole area. However, in most of the cases, you're looking out towards the golf course, over the river, or off to the south and that. So a lot of the views, I think, will be very nice from those upper floors.
Assuming that would be part of the final phase of construction, so what type of timeline would that be? Towards late 24, early 25?
In general, they're looking to start piling next month, and as we're finishing up the rest of the design, and it's approximately, I think, about 2 years or 30 months for construction, so roughly into 25.
2 questions. What are you doing about isolation of one area from another? And what are the heights of the interior walls?
So there are a couple key COVID things within the building. At our key entries, so specifically like the staff entry and related to the front entry, there's additional area accommodated for screening and checking to be able to have those, because a lot of existing facilities, it was quite hard to accommodate some of that check and registration as they're coming in. Within the current standards from a ventilation standpoint, it's kind of amazing how much air goes through a hospital. It's especially the inpatient wards and the emergency and that. So there's a lot of the area is outdoor fresh air that's brought through and managed to meet those current standards for that. As for walls, the vast majority of walls in a healthcare setting do go slab to slab, just from both fire separations and creating those pressure differentials and the ventilation standards for that. So most every wall in the building, other than some office spaces and that, will really be full height walls.
Full height as in 8 foot, 14 feet?
Well, the floor-to-floor height is it's in meters. The main floor is higher at probably about 15 feet, and the upper floors are about 12 feet or so. But it would go right up to the slab above the ceiling. So you have a ceiling at about 9 feet in most areas, and the wall would continue up higher to that, up to the slab above.
Can I ask a follow-up, kind of related to that? You mentioned that there were airborne isolation rooms. What are those used for? Is that for something like COVID, like someone?
Yes.
Yeah.
So in, I'll say, non-COVID times, key use of that would be for patients with tuberculosis. So if they're potentially contagious, they would be there'd be procedures and protocols of bringing them into that space, and then there's an additional room that we call an ante-room, where the staff put on and take off their protective equipment, or protective PPE. And before coming into the room, there's special ventilation there. All of that air is completely exhausted out to the exterior, so that none of it gets recirculated back into the building, or no potential of it being recirculated back into the building. And there's pressure sensors on the wall that let staff know that those are active and working.
I don't hear any mention of the special care or intensive care area. We have that in our present hospital. Intensive care, monitoring beds for cardiac patients and acute.
I'll let Prairie Mountain Health answer that one more accurately than I can.
So Dr. Allen, those would be in the ER, so we've made accommodations in there for, and we'll staff it so that those patients that currently, I know where they are, they're currently blocked, but there's space in that emergency department. So anybody that needs that extra intense one-to-one care for a period of time to see if they can stay or do they need to be transferred out, we will keep them in that emergency department. And if we're able to stay, then we would transfer them out to the medical unit. But we've made accommodations in that area.
So how sometimes patients require intensive care or intensive monitoring for days.
Right.
So you're going to keep them all in the emergency department?
Yeah, so we'll have to work through policy procedure on that. So what would be the timeline? So would it be 48 hours? Would it be 24? Whatever that would look like. Again, that's some of the operational things we need to work through. There may be opportunities still for them to be maybe cared upstairs, but we would provide one-to-one. It depends on the monitoring pieces you said, right? So those monitoring capabilities are going to be in emerge, for sure. Yeah.
We'll go with the middle one.
Have you guys considered a provision for pediatric care?
Pediatric care, so pediatrics would be managed on the inpatient unit. And if, in fact, they needed to be transferred out, same as what you do now. But there is accommodations that pediatrics would be on the medical ward. Babies, yes, the babies will stay with the mom. There is in the plan you'll see across from where the labor and delivery rooms are, there's an area there to stabilize a baby that's maybe unstable, and so there's a specific area for that. But again, it's just for the stabilization and then to send out. So I don't know if I've answered your question completely, but so those are the two areas. Sorry.
Yeah, because we're considering that the town is growing and there's a lot of young generation that are coming here, and lots of the nurses or like the new employees that we're anticipating would be, maybe young families would have, young children. And like for me, I have 2 children and I have to go to Winnipeg to get them checked. There's no pediatrician in town.
Oh, okay. So if so you're talking about a family practice, like a family physician or a consultation, or not inpatient cares? Am I understanding?
Well, it would be for both.
For both?
Yeah.
So again, it depends on the stability of the patient, right? There's things that we can provide in Neepawa, there's things that would need to go to a higher level of care. If there needed to be consultation, when I was talking about very much having the virtual capabilities, the province is looking at supporting, keeping people closer to home, provided that it's safe to do so, and providing that consultation through technology. So things like, you talk about FaceTime. It's a similar type of technology. So that's been built into the hospital where there's areas where they can do that consultation. If in fact it's an appointment through, say, telehealth, some of that's done now, there's space in the hospital to still do those appointments as well. So there's immediate emerge consultation that would be available once that's set up provincially, but then there's also still the capabilities through telehealth, which you may be doing some of that consultation now.
Okay. I'm sorry, I just want to piggyback on Marianne's question. So there's not space for or capabilities for NICU, right?
No. Okay.
Okay.
No.
And that would be in Brandon. That would be where the babies go that need to be in the NICU?
Yeah.
Okay.
We would transfer any baby requiring NICU services would be transferred out, same as they are today.
Does the expansion of the hospital correlate at all to women with higher risk pregnancies being able to birth in Neepawa, or would they still probably have to go to Brandon?
So depending on the risk, so Dr. Distelay is here, so she could probably explain that a little bit better, but there are some pregnancies that absolutely should be managed and transferred out. But the doctors here, they do that assessment and make that determination. Neepawa, we would consider it low-risk obstetrics.
Okay.
So the physicians make that decision in terms of if it's safe to have them deliver in the Neepawa Centre, or if they need to go out for tertiary care.
You have capabilities of doing emergency C-sections?
Yes.
Just not planned
Planned
C-sections?
C-sections too, so
Oh,
they do
okay.
planned C-sections now, so
Okay.
that would continue, plus emergency C-sections.
Okay, perfect, thank you.
You got a question on the, yes?
Yeah, well, I was actually going to ask, you as well. But also I had a question, this is actually regarding staffing, so I don't know who this would kind of go towards. But given the sizable staff, we talked about training and recruitment, well, has there been any consideration given to things like staff daycare, things like that?
So that was on the table originally. There was a question about having a daycare program, and we weren't able to proceed with that. It's just not something that typically a health center would put in. Typically that's private. So there just wasn't the ability and the footprint to have a daycare within the facility.
I have another question, I'm sorry. You know, Neepawa is very, very multicultural, and, you know, I know you've been working with settlement services and things like that. So if a family needs a translator or something like that, where would that be held? Would that be in those family rooms, or?
Yeah, so there's ability for translation to happen in any patient room,
Okay.
right? So, and there's policy within Prairie Mountain Health in terms of accessing interpreter services. So it would be, you could have that happen anywhere within a healthcare facility.
Nice, so it's
just
not limited to,
No.
okay, perfect, thank you.
Right.
It's mechanical. So for the,
I
well,
am not a mechanical
recently
engineer.
Victoria Hospital just had a fire and they had the sprinkler system that went off and damaged a larger area than necessary. And we've had buildings in Prairie Mountain Health that have had frozen fire lines. Are you isolating the areas with your fire protection? Are you keeping these lines from the ability to freeze?
So the sprinkler will be in zones, which connects into the fire alarm and, you know, tells the firefighters where a head has gone off and that. So that would naturally be segregated into zones based on fire departments and the building code, the fire code. There will be few cold heads. Spaces where we would have it, or we're protected for, is in the ambulance garage, because sometimes those doors are left open for an extended period of time, as well as the canopies at the entry would typically need to be sprinklered, depending on some of the construction and the connection points to the building and that. So they would likely also have sprinkler heads that are in there that are rated for the exterior and so that they can freeze without causing damage. Yes?
I'm just wondering about the access off the highway. If there's going to be a frontage road or something, or I'm thinking about shift change with High Life, it's just impossible to get on or off the highway if
Yeah.
there's so much traffic.
Yeah. Maybe do you want to touch on that one, or?
Maybe even Pauline, yeah.
I'll speak to that.
Yeah.
So right now, we're still in the, excuse me, in negotiation on roads and that, but there will be an east-west and a north-south road. You know, and I guess you have to look at it from the aspect that, you know, just about every hospital that is built, there is accesses and that, but at this point, there's a lot of negotiation that has to go on. So I will say that, yes, that is in the works. One comment that I'd like to say is actually for having done a fair amount of building projects myself over my career, this is the most detailed plan that I've ever seen, and to be able to do mock-up rooms like that, that's tremendous, and I think that's a real credit to your planning. And if your group decides to ever want to come and do co-op projects,
I'm just wondering, and this maybe would be for Brian to answer too, is that currently any residents up there don't have town sewer. So are you going across the river, or where's the sewer line going?
Yeah, go ahead.
yeah, there again, it's all in planning. You know, and so with a project of this size, The biggest problem that you can make is trying to do too many things at the same time. So right now, we're concentrating all our efforts around what exactly is making sure that this project is completed over the next 2 to 3 years. And yes, of course, we have to have water and sewer, but along with that, there has to be additional planning for what if there was a future for something else around there. And so there's a lot of planning that has to go into this. Is all those fine details completed? No, they are not. But do they have to be in place here for the opening? I would say so, yeah. So yes, it is in the works, but again, there's just so much planning that we're working on.
So I did hear, so a little bit of a piggyback off Miranda's question there. I did hear that there would be some facilitation of mental health access, that sort of thing. Is there any plans on expanding that? And is there any sort of plans to have like an in-house social worker, those types of resources for patients and access to resources within the community?
Yeah. So the staffing plan does have a social worker, and the staffing plan does have a mental health resource nurse as well.
If I could piggyback off of Amanda. Sorry. You know, when someone comes into the emergency room with a mental health crisis or issue, are they going to be triaged along with the physical health issues, or is that going to be a different triage system for mental health?
So it depends how they come into the system, right? So depending on which way they come in, then they would be put into the appropriate space, right?
Okay.
Yeah.
Okay.
Yeah.
And the social worker, will there be one on there all the time or on call? Or?
So the social worker, right now, it would be on days. The mental health worker is, I believe it's a 12-hour person, 7 days a week, but.
And what would happen if someone came in crisis, like overnight?
So there's systems in place to have consultation virtually as well, so for after hours. So that exists now in the province, so that would be used as well. Yeah,
that's good.
Yeah.
Well, thank you very much for your interest, and it's really great to see you all out here. Oh, yes, Ken.
Yeah, sorry. Go back a little bit in history. You know the history very well, Brian, but the plan at one time was to locate a hospital at the site of Country Meadows, and I know that's been considered and rehashed and everything, but could you summarize some of the decisions as to why it didn't happen that way?
Yeah, so first of all, you'll see that the facility is quite a bit larger than even was originally planned. And a lot of that has to do with single rooms, larger spaces. So the facility is very large compared to any other hospitals really out there. So the space right beside Country Meadows wasn't big enough. And so we had to go and look for other space. So there was a number of lots looked at. There was, of course, the municipality, the town was consulted. There was a lot of work looking at different parcels. It really came down to this property that's been purchased here is 39 acres, if I'm not mistaken. And of course, you see the helipad, etc. So and the potential down the road if there's any expansion. So it was really about size, and it was about price for that size. And that's really why that location was selected in the end. It wasn't that there wasn't options, but definitely this was the one that ticked all the boxes.
Thank you, Brian.
Okay, again, thank you very much. I'm going to say something outright, and I know you didn't ask the question, so you're probably wondering why is he going to respond to it. But there's been a lot of, questions about how are we going to staff this facility. So I'm going to say, first of all, the facility is built for the future. So we're not necessarily expecting that we will need to staff every single room in the building right at the start. But in addition to what was already mentioned regarding the work that's being done to try to have the LPN course here next year, there are a lot of things being done provincially and by the region for recruitment. So for example, They're looking at offshore recruitment, they're looking at, we are also looking at a program that's being offered by the city, but it's within jurisdiction, or Neepawa's within the jurisdiction, where we can look for immigration as well. So there are a lot of things going on for recruitment so that we are ready when the time comes. We have a few months, but we are working very diligently on that. And I just want to assure you that we're doing everything we can. We know there's shortages, but we're very lucky to have such a beautiful facility, a beautiful community, and that definitely in itself will help with recruitment. Yes.
One thing that I was curious about, and you're speaking now, brought it back to my mind, is the on-call doctor, the emergency doctor that has to be there 24/7, 24 hours. Is there a place where they can be so that they're not coming in
Yes.
on site?
Yes, we do have those 3 rooms, I think.
Okay, thank you.
And the model has recently changed in that regard, and so that's obviously very important that we're accommodating we call it a sleep room for the physicians or a quiet room for the physicians.
Can I ask a follow-up question about recruitment?
Mm-hmm.
As you know, I think it was before Christmas, Manitoba's Health Minister Audrey Gordon, announced that they were going to be doing all of these things to try to recruit more doctors, more nurses. Like what you mentioned, like offshore and things like that. So do you feel like with what Neepawa has in place and what Prairie Mountain, and then with the province, are you optimistic that, as you said, the hospital, the town will grow into it and the recruitment will follow suit? Do you feel optimistic?
I do feel optimistic. I'm not saying that we're going to have everything and everyone needed, but I can say that if you only knew how much was being done collectively by the system, and we are competing not just against the next community or the next province, or it's right across the country, but I think we're all working very hard to try to alleviate those staffing shortages. So I just don't want to avoid the issue because it is an issue, and I want to acknowledge that.
I have a question about the recruiting thing. I noticed in some rural areas in the past that they do kind of a bursary student loan program where they send local people to get training and they get it coming back.
Yes.
Has there been any discussion about doing something like that in place?
Well, there's been a lot of discussion, and it's really based on discipline. So we are talking about that for a number of areas, including physicians, for example. But we've done that for nurse practitioners. There are grants, and both from the region and from the province for some of those disciplines that people can access. So, and also in addition to the additional spots that are being offered in the province for those positions, that's important as well. So I'm going to make you all recruiters tonight, and not recruiters in the sense of somebody who already has their education, but recruiters in the sense to encourage our young people who, have a great opportunity to stay in the community and have a great job at the same time. And I'm talking men and women. I'm talking, let's talk to them when they're young. There are great opportunities for people to have a great career, and they can have it right in their own backyard.
I keep getting asked by different groups about, raising money. What does the hospital need? What are you not going to pay for that we actually need? And what do the doctors really want that you're saying no to? They want to know what they can raise money toward.
So the facility and its contents, its basic contents are all paid for, okay, by government. The communities surrounding are responsible to pick up $6 million of the costs. Now, some of those costs could be anything from, infrastructure to whatever's needed to have that site serviced. I think what's important is that If there's extras that the community wants to contribute to, there's always that opportunity, as long as it's done within the planning of the project, right? Not a one-off, but done within. So there could be extras that are provided, etc. I'm not really the right ones to ask. Probably Debbie and her crew would be the ones to do that. But the community always has an opportunity. But remember, your community will already be contributing through the community contribution portion of this project.
I'm thinking of the Neepawa Health Auxiliary Group. They're looking toward, can we do a project, can we put something in? So who would you direct them to contact to get that information?
I would say Debbie Poole.
So many moons ago, the province recruited from the Philippines and then did a bridging program to get the nurses working here. We have a significant amount of RNs that have come to our community over a period of time and will continue to come over for a period of time. Is that not something that you would consider as well?
Absolutely, and actually that's a common subject at our tables, is that it's not just about foreign recruitment, it's about ensuring that the people that are already here are hired. Now, there's a lot of issues around that, and it has a lot to do that is out of our control, but we are working there too. That is very important for us because we know there are a lot of professionals, particularly nurses, that are working here in the community other than healthcare, and it would be great to have them working for us. Yeah, no, you're dead on. And we're trying. And collectively, we're trying as a province, so just let you know that too.
The other question I get asked is, what are you doing with the old hospital?
I don't know if that's all figured out. My understanding, I'm scared to say this, but I think that the property actually returns to the town. Okay, but there's a few caveats regarding that. We have our public health services and such in a building that's adjacent there that has to be dealt with. So I'll leave it at that. But there's more discussions. I like how the mayor responds. That not everything is figured out yet. But those are my original understanding. Yeah. Yes?
Increase in staffing, is there any provisions for housing?
No, we don't look after that. I think that's something that the town has to look at. And remember, this will be over time, but I think every community that is looking to entice professionals to the community, that is one area that's very important, whether it's temporary, permanent, but I'm just saying that that's always an issue, right? Housing, and I know in this community it's not easy to get a home, so. Well, thank you very much. I won't keep you any longer, and it's been great having you out.